by this powerful panel that we have here this afternoon to treat us to some thoughts surrounding the business of sports and medicine. I'd first like to introduce to my immediate left Dr. Shamali Rupchand Martin, who is in fact the head of the Mona Academy of Sports here at the UWI, and she'll be presenting on data on barriers to exercise in persons with spinal cord injuries in Jamaica. Okay, give her an acknowledgement, please. Okay. Thank you. Next to her, I have Dr. Rory Dixon, who is the Senior Medical Officer at the Sir John Gordon Rehab Center and is also a member of the International Paralympics Committee. He will be looking at exploring the sports management assessment protocol for athletes with a disability. Let me hear it. Okay. Thank you. And nextly, there is Ms. Susan Harris Henry, Secretary General of the Jamaica Paralympics Association, a physiotherapist par excellence, and she'll be talking with enhancing performance and sports injuries prevention in disability sports. Let me hear it. Thank you. I'm still kind of hoping that Dr. Paula Dawson, founder of the Rehabilitation Institute of the Caribbean, will join us, and we will maybe hold her applause until she gets here. Okay?
She won't hear it.
I'm a little bit delighted to have this panel, delighted in my own right, because these three stalwarts have, over the years, every year, hosted my own graduate students, my own neuropsychology graduate students, in their facility down at the Sir John Rehab Center. I take them there every year to learn more about our business of brain injury. And these are the stalwarts who have, over time, many years, been able to guide them through. Okay, so publicly, my friends, just want to say thanks. Okay, give me an opportunity to really express my appreciation. And I might tell you that it has always been a highlight of my students' neuropsychology experience with me at the university. So, that being said, you must know that our panelists will work for about approximately 10 minutes each, and there will be, am I correct, IT, that their presentations will be beamed to the screens as well? Okay.
It's supposed to be, but it's not.
And I'm hoping that that will be the case. But without any further ado, let me, in order of I introduce my colleagues, start with Dr. Martin in her presentation, okay? And I'll ask the panelists to present consecutively, after which time we will reserve some time for questions and answers, okay? Dr. Martin, thanks.
Good afternoon, ladies and gentlemen. It is a pleasure to be here. I will get started. If this screen comes up, great. You'll actually be able to see some of the data. If not, I'm not going to hold up. We need to keep going. So I'm going to talk to you a little bit about some data that we have here looking at barriers to exercise in persons with spinal cord injury in Jamaica. And before I get fully into it, I would like to acknowledge Susan Harris Henry, who was one of the persons involved on this project as well. And two students, they were then students when we were collecting the data, they are now fully qualified physical therapists, Shanika Graham and Crystal Gale. As in the country singer Crystal Gale? Not really. Now, in the past, one of the most common causes of death from spinal cord injury has been associated with renal complications. But in more recent time, cardiovascular diseases have been or have become the more significant contributor to early death in persons who have been suffering with spinal or who have been affected with spinal cord injuries. Is that any different compared to the average population? Not really. All of us who do not have any form of disability, one of the biggest contributors to death today is also cardiovascular diseases, whether you have a disability or not. When you have a spinal cord injury, your risk goes up a little bit more because you're no longer up and running up and down as other persons are on their legs. You're relying more on the upper body for your physical activity. The upper body muscles are not as large as the lower limb ones, so the actual exertion levels and the pumping action that you can get is a bit reduced, which means that someone with spinal cord injury has to work a little bit harder to get these benefits of exercise. There's a lot of data out there which shows that even for persons who have had a spinal cord injury, engaging in regular exercise can reduce the risk of these cardiovascular disorders and can lead to improved quality of life for persons. So we wanted to look at what persons here in Jamaica were doing with regards to exercise. These are persons who have been discharged from the John Golding Rehabilitation Center. So they would have been through the inpatient rehab, some amount of outpatient rehab for some persons, for others completed their outpatient rehab and they were now back home in their communities. And we were interested in whether these persons were engaged in any form of exercise, and if not, why were they not involved in exercise? So what we did was we identified all persons who had been discharged within a 10-year period from the center. This was 2007 going backwards. And of that, we were able to track down 50 persons that were still alive, still had contact information that we were able to reach them on. And we took them through 2 questionnaires, one looking at their physical activity levels and the other one looking at their perceived barriers to exercise and their concerns about engaging in exercise. Now, what was interesting during that process, before I get into that data, was a number of those persons actually indicated to us that they had self-discharged themselves from the center. And why did they self-discharge themselves? What do you think? Anybody? Can't bother. Somebody said something about...
They think they're functional. Okay, that's why they discharge themselves.
They think they were functional.
Not progressing fast enough.
Feel that it wasn't beneficial. Financial. So everybody is wrong except for part of the last answer. So people self-discharge because what they're commuting to and from where they live to the center was extremely challenging and the cost became a problem for them. So a number of these persons would have gone home without completing their rehab process, may not even have been at levels that they even understood what they should be doing going forward with regards to routine exercising. And I found that quite concerning actually, because it's not that the facility is saying, boy, we can't cope with you. They're self-discharging because of cost factors. Alright, so just to take you straight to the data a little bit. So what we had, the majority of our persons who participated in the study were fully wheelchair bound. We had a few who were using a cane, and we had we had one person actually who was actually able to use a walker. So this would have been, the cane and the walker would have been persons with incomplete spinal cord injuries. Now, when we asked them questions regarding would you actually be interested in exercising, you'd see that most of the persons said yes. For those of you that are not able to see my slides, that figure represents 83% of the group. So 83% of our group are interested in exercise programs. Have you ever exercised? We had 87%. But as you move down to look at, do you know if there's a fitness center, or do you know of a fitness center that is close to you or that you can actually access or get to? You're seeing 43%. So only 43% being aware of somewhere that they can go to. And if you follow that 43% all the way down, you're getting to only 6.3 actually being in a situation where they can afford to get to a center that would allow them to engage in exercise. So 41% would be able to transport themselves, but then only 33% indicated that they would be able to afford to pay, and then could they actually really and truly spend this amount? We're down to 6%. So you're seeing the financial that was mentioned earlier as a reason for incomplete rehab beginning to impact on not exercising as well. We were curious as to whether they would have actually been concerned about just going to a regular gym, because when you leave the safety net of a John Golding rehab, where you have qualified professionals working with you in terms of medical, and then to go after a gym where it would be just an exercise person, and I'm saying just because I don't mean it in that way, it's just patients tend to see it like that, you know, oh, but this is my physio, this is my doctor, and I'm going to a gym instructor, right? And I have special needs. We wondered whether persons would be concerned about going to a gym with a gym instructor. And interestingly enough, what we saw was 77% indicated that they would be concerned about going to a gym to exercise. They're worried about their condition and just going to the gym instructor versus coming back to the center itself to engage in an exercise program that would have been housed at the rehab center. Do they feel that, or do they feel that a gym instructor in a fitness center could set up a program for them? They felt yes, they could. A gym instructor could set up a program, but they also still felt concerned about going to it, right? I want to point out the one down at the bottom that says, has your doctor ever told you to exercise? Only 43% indicated yes, which is very interesting because these are persons that a big chunk of becoming at your highest level of functioning is dependent on exercise. Your whole quality of life is dependent on exercise. And I find it interesting because I can almost hang a hat on it and say, at some point, a doctor or a physiotherapist would have told these persons about exercise. The problem is it may not have been emphasized necessarily in the way that it should. So what remains in that person's brain is that nobody really ever told me about this, because they're not seeing it in the context of this is something that I have to do for the rest of my life. So, you know, it really speaks to a deficit on our part in healthcare with how we educate persons about exercise and the role of exercise. And this is something you see across the board, even in persons with no disabilities. You go to the average health center and you do a survey of elderly persons and you ask them, has your doctor told you about exercise? No. I heard somebody mention drugs. They tell you about all the drugs you have to take, right? Concerns in relation to exercise. There are two things that I want to highlight in particular for you. Major concerns really around the cost of an exercise program and somewhere to go for exercising. It's only a small number of persons that you're seeing where lack of interest and lack of time is an issue. 14% saying lack of interest, 12% lack of time, 6% exercise is boring, right? The bigger concerns is really about what this is going to cost me and not knowing where to go for exercise. Motivation, energy, that lack of interest, those are the top barriers in our developed countries. So if you look at surveys coming out of the US, out of Canada, you're going to see things like lack of motivation being bigger barriers to exercise than cost. On our side of the world, we're interested, we're motivated, but costs and facilities being available. Right? And these are some others coming out. Laziness, small percentage for laziness. Not knowing how to exercise, 16%. So you're seeing smaller numbers there. The big one that I want to draw your attention to is the lack of transportation. Down at the bottom, 62.5% had concerns about transportation, not being able to access transportation. So even if they had somewhere that they could go to exercise, transportation becoming problematic for them. They'd have to be depending on family members, which then feels like they're being a burden because that person has to take time out of their work, their jobs, whatever, and we don't have the public transportation infrastructure for everywhere that will facilitate transportation or independent transportation for these individuals. Right? I mentioned this already while the slides was out, that many of these individuals actually did not complete their rehab because of the same barriers we're seeing to why they didn't exercise, right? Cost, their ability to easily access the facility, linked back to transportation, and what several of them said was they were actually unemployed already. They didn't want to become burdens on their families, so they already saw themselves as being a burden, and they didn't want themselves to become an even bigger burden by harassing family members about taking them to exercise in areas that were going to be costing even additional money. So what it resulted in is persons really not participating in exercise, which probably ends up with bigger costs down the road because of the other health problems that results, and then you still have to find your way to hospital, treatment in terms of other medications for the cardiovascular problems that will occur. So some of the things that we want to conclude out of this, we know, and I think anybody could have probably said that from the beginning, they figured costs would have been an issue, right? If you look at who primarily has spinal cord injuries in our population, it's persons from lower socioeconomic brackets, right? Access, certainly coming out there, not having enough facilities and affordable facilities that persons can go to for exercise. So not having enough, not having access to these facilities as well became a problem. Education, and I put education because it's obvious that persons need to be educated about the importance of exercise, and I think they need education about what they can do from even within their home environment. You do not have to leave your house to go to a special facility or a gym to exercise if you are taking through things that you can do within your home environment. So I have a big one there that says the need to be creative. A big chunk of a person's rehab as they prepare for discharge should be integrating creative means of how are you going to exercise within your own home environment. So discharge programs and follow-ups within the community I think is important. At intervals doing follow-ups to see are you still exercising, modifications to the exercise programs, but trying to keep those exercise programs within the home environment. That I think we can address. It's a bigger challenge to address the cost, the transportation, the infrastructure, right? Because that requires even more in terms of input from government and other sectors in terms of financing. But certainly we can look at mechanisms for addressing programs in the home, in discharge planning, and in education. Pick up a phone, build it in. Pick up a phone and follow up. You've been home 2 months now. What's happening? How is your exercise program? What are you doing? And do a check through by phone. If persons know that they're being checked up on and somebody is, following up with them, touching bases with them, they're more likely to...
Dixon. Thanks, Dr. Richard Martin. And we'll ask Dr. Dixon to present now, please. Thanks.
Okay. Good afternoon, everybody. I'm here to speak about the assessment protocol for persons, well, for athletes with a physical disability. Specifically, a physical disability, because as you know, there are many different types of disability. And I'm involved with the Paralympic Association, so I'll speak about the areas I'm more familiar with. Just to refresh our memories, a disability is any restriction or lack of ability to perform an activity in a manner or within the range considered normal for a human being. And of course, a disability results from an impairment. So the next question is, what's an impairment? So it's a loss or abnormality of psychological, physiological, or anatomical structure or function. So visually, we can see what a physical disability is, but there are many impairment, but there are many different types. So there's developmental, self-help, mobility, physical, which I'm going to focus on. And as you can see, the list there: behavioral, communication, educational, mental, social, employment / economical, or environmental. So, we'll speak about the Paralympic athlete. So, as we all know, sport has always been an integral part of rehabilitation for the disabled. And sport and recreation are vital for socio-cultural integration and equity, harmony and cohesion, particularly among persons with a disability. So this all started back in 1948, after World War II, with hundreds of active young minds in wheelchairs. So Sir Ludwig Guttmann, at the time in Stoke Mandeville, England, started what was known as the wheelchair games. And this went on, but this only involved persons with spinal cord injury initially. And it became international 4 years later when persons from the Netherlands joined. And the rest is history. So the first games, which we know as Paralympics, took place in 1960 in Rome. And it developed over the years. And in terms of the number of athletes, we're looking at 400 athletes in the beginning, and the last games that were held in, what was it, Rio?
Rio.
Yeah, last year in Rio, we're looking at almost 5,000 athletes. And it has become so competitive that athletes are now being selected based on ratio per population. So as small as Jamaica's population is, we still can't get enough athletes to participate because our population is small. And of course, Jamaica has a long history in these games since 1960. We did very well during that time, especially in swimming and archery and other sports like that. But swimming is being redeveloped at this now. So these are the events that take place in Paralympics. I've highlighted some of the events which are low cost, meaning that it doesn't take much in terms of equipment, and events that we in Jamaica are trying to maximize participation. So how does somebody with a disability, physical disability, become, how can they participate in Paralympic sport? There are 8 categories, actually 9 categories, which are listed here. And to simplify it, with respect to the types of disabilities, there is a group that you call a cerebral palsy group, which is divided into 3 different types. So based on the type of cerebral palsy, you may be hypertonic, meaning that you have increased tightness in your muscles. You may be ataxic, meaning that you have jerky movements when you try to walk or to use your hands. Or you may have what you call athetosis, in which there is involuntary movement of the limbs and can be seen on the face as well. There is a group which we call limb deficiency, which refers to, for example, somebody who is born with one limb which is longer than, more developed than the other limb, and say maybe upper limb or lower limb. There is a group with impaired range of motion, For example, somebody born with a condition called arthrogryposis, in which there is limited, there's loss of the full range of motion of the joints, particularly ankles, hips, knees. Then there's what they call the impaired muscle power group, and this was the original group, the spinal cord injured group. But impaired muscle power also now includes persons, for example, who are born with Erb's palsy, or persons who develop a nerve injury subsequent to some incident. Then there's what they call limb length discrepancy, which also includes, for example, somebody that has a focal deficit of a lower limb. And then there is a group which we refer to as the nanism group, or short stature. These are persons with a height of roughly 125 to 130 centimeters in height. And there is a visual impaired group, and also the hearing group, and there is also the intellectual impaired group. But for Paralympics athletics purposes, I focus mostly on the other group except for the visually and the intellectually impaired. So, how are these persons selected? Let's say, for example, you have a deficiency of your upper limb. Let's say you had an amputation of your hand for whatever reason. Each athlete is selected by a process called, they're first selected by their national sports committee. For example, persons that come to the Surgeon Glen Rehab Center either for rehabilitation or for clinic purposes, if they have a physical disability which falls into the categories above mentioned, they are assessed, first of all, to see if medically they're fit, and also if they have an interest in participating in sport. So my capacity as a medical classifier is now to assess this person to see is their disability eligible, meaning that do they meet the minimum disability criteria for each category, and once meeting that minimal disability criteria, which class is this person going to be placed in? When I mention class, there are two major classes in Paralympics. There's what they call the seated class and the ambulant class. So the seated class would have 30s and 50s in terms of their numbers, and then the standing class have their different numbers as well, which I'll mention briefly. So to understand classification, for example, we all know at champs there's class 1, class 2, class 3 based on age. In boxing it's based on weight. For disability sports it's based on the degree of function which is presented by your disability. So to simplify it, if we see a group of athletes with amputation of their lower limbs, persons with amputation below the knee would go into one group, and persons with amputation above the knee would go into a group, and they would form two separate groups. So if they run together, there is even competition between each group. So I mentioned eligibility, and of course there's what we call the medical diagnostic criteria. And the disability must be, the impairment must be unchanging. For example, if let's say you have an injury on the football field, you fall, get a injury to your neck, and you lose power in a limb. This person cannot automatically come forward for classification, because one has to wait until they've recovered their what you call maximal improvement. So you have to wait at least 18 months to see if what they have is improving or stable. And once we establish that it's stable, then you can assess them. And of course, if there's any surgical intervention, that may also change the classification. For example, let's just say for the lower limbs, you are eligible for Paralympics if one leg is 5 centimeters shorter than the other. If, for example, the person had surgery at University Hospital and did a limb lengthening, the fact that they were born at 5 centimeters short and did a limb lengthening now makes them ineligible, because they would now be not 5 centimeters shorter. Alright, and of course for pediatric athletes, they have to be reassessed on a regular basis because they're growing and their measurements can change. For example, somebody in the dwarf group as a child, you cannot confirm them because in a year they may grow and exceed the height limitation and therefore not be eligible. So we place these athletes in what we call a review group. And the review group, persons with limb deficiency, incomplete neurological deficit, or conditions that change such as multiple sclerosis, the short stature group, the visual impaired group, and if there is any surgery. Just to give an example of what we call the sports class, this is what we call T47. T stands for track, and 47 is the minimal disability criteria for somebody with a deficiency in the upper limb. And a measurement is taken from what you call from the tip of your shoulder or the acromion to the what you call the styloid processor just above the wrist on the normal side, and that measurement must be more than the distance of the entire limb on the affected side. So once the affected side is shorter than that distance on the normal side, then this person is eligible as a T47. And because this category, there's not much equipment that's needed, just training. We have our own T47 runner, and it can also be applied to persons with both limbs that are affected. And this is still on. Yeah, so this is one of our junior runners.
And he's going to the Commonwealth Games.
Oh, and he's going to the Commonwealth next month. This month.
Let's leave this month.
Okay. How are we in Jamaica trying to empower persons with physical disability to participate in sport? As mentioned by Dr. Rupchan earlier, there is a financial constraint with exercise and of course participation. So what we have done is target most of the activities that don't require much in terms of equipment. So we have a few runners, upper limb amputees, which they don't require any equipment. The lower limb amputees, they will require an artificial leg for running. And an artificial leg can depend on the technology used. I mean, we're looking at up to 10,000 US for a leg, and that's a simple leg. So the athletes that we have represented Jamaica currently are the upper limb amputees, as I mentioned before, persons with cerebral palsy, we have a few visual impaired athletes, spinal cord injured athletes, and persons with short stature. And the events that they usually participate in are minimal equipment as well, such as field events, shot put, javelin, discus, and track. So this is our team that represented us last year. Not well. In terms of training, the same rules apply to persons with disabilities as regular sports. full knowledge of the wider list of restricted drugs. Everything that's taken is ingested is screened, and of course injury and prevention detection, which Susan will mention, is also part of it. In terms of training, I'll leave this part to Susan, so I won't expand on this. But training, especially person spinal cord injury, is a little bit different because you have to take into consideration that the blood flow is impaired and the sensation is impaired in their lower limbs. This is our first Jamaican lower limb amputee runner, and courtesy of Surgery to Jamaica, an artificial leg was made for him last year, and he's currently in training. With respect to participation in events, it takes a lot to participate in games because of traveling and the requirements of traveling. Persons with disabilities are required to have adequate able-bodied persons to accompany them to assist with logistics and things like that. Injuries occur as well as in able-bodied athletes. For persons with spinal cord injuries would be more will tend to occur more in the shoulder because they tend to they'll have to use their upper limbs a lot more. And of course, depending on the sport that they are participating, they'll have specific injuries. For the visually impaired athlete, the challenges we have is that depending on there are three categories of visually impaired athlete: T1, T11, T12, T13. T13 is the most, they can run by themselves, whereas T11 need a guide to run with them. The challenge with the T11 class is that the guide needs to be as good as or better than the runner. So we have a challenge finding guides that can accompany a runner in the T11 class. So how do we continue to develop Paralympic sports in Jamaica? Currently, most of the training takes place at Surgery and Rehab Center, but we have expanded to utilize the services of Racers Track Club, or upper limb amputees actually train at racers. We're trying to incorporate disabled athletes into regular sports programs throughout the island because it is impossible for everybody to come to Kingston to train. We have participated in local events. We're actually putting on the UTEC Classic as a Paralympic event. When is it again?
It's April 14th.
Which will be in April this year.
Yes.
And one thing that we can say for sure is that public awareness and media coverage has substantially improved over the years. And of course, without the assistance of our NGOs and sponsors, sports, as you know, is difficult to participate in. So just to mention a few low budget sports: boccia for a person with severe cerebral palsy. There's seated volleyball, which is low budget. Goal ball for visually impaired, which uses a ball with a bell inside of it. And thank you very much.
Thank you, Dr. Dixon. Without further ado, somebody throw on, guys, so let's hope we get some time to have some questions. So let me ask Dr. Susan Harrison.
Not doctor, not doctor yet.
To present for us at this point in time. Thanks.
All right, maybe he's speaking it into being, why not? All right. All right, I'll see how fast I can go. All right, because I'm sure my time is very restricted now. But just wanted to look a little bit at the national sports policy, because as far as you can see, this is what I'm talking about: enhancing performances and sports injuries prevention in disability sports. And so the national sports policy is to ensure the promotion of a healthy society and the strengthening of appropriate regulations and legislations that support and facilitate sporting initiatives and activities that will result in increased participation among all Jamaicans with or without a disability. Furthermore, as a signatory to the Convention on the Rights of Persons with Disabilities, the policy seeks to promote and encourage participation to the fullest extent possible of persons with disabilities in mainstream sporting activities at all levels. I just wanted to mention that, you know, in terms of sports for persons with disabilities, there are 3 categories, and we've all heard them: Special Olympics, Deaf Olympics, Paralympics. And Dr. Dixon defined disability, I'll just define Paralympic, that the term Paralympic derives from the Greek word Olympic, and the suffix para is a Greek preposition which means close to. So we don't say Paralympic, we say Paralympic. So we take out the O. Alright, and Dr. Dixon also went over the events in which we participate. This is only in the summer games, because they do have a winter games, which is actually underway in Pyeongchang, South Korea. Right, so, but we're not there yet, but the dream is one day we just might be there. And I just wanted to show you some pictures of some of our athletes. And at the top is Alfonso throwing javelin, below that's him throwing the discus. Above is not our athletes, but I just wanted to put Blade Runners in. And then at the right hand corner is Shane Hudson, one of our, well, went back to Dr. Dixon's presentation, T47 400-meter runner, and I would say pretty successful. He has won medals at most of the major games. And again, just to show you that in terms of equipment, if you're doing wheelchair basketball, you have a specialized chair. Sitting volleyball, wheelchair rugby is another specialized equipment. Wheelchair tennis requires specialized wheelchairs. All of them, well, except sitting volleyball, all require specialized wheelchairs. And you'll see the point that I get to in terms of how that can enhance performance. So that in enhancing performances and sports injury prevention, the factors that enhance athlete performances and ultimately prevent sport injuries include sport, and I don't know that this is an exhaustive list, but this is what I researched and this is what I came up with. So sport-specific skill, muscular strength, power, flexibility and speed, nutrition, equipment, training opportunities, accessibility, coach knowledge, financial, psychological support, support from the international body, in this case the International Paralympic Committee, support from the local sporting body in terms of the Jamaica Paralympic Association, and certainly anti-doping. So just looking at, as brief as possible, at all of the areas, all of the factors. In terms of sport-specific skill, it's to ensure that athletes with an impairment are assigned to the sport that's right for them. So it's not only just the class, but it's the sport that's right for them. So they have to have the right body type. You certainly wouldn't want somebody who is big and bulky to be, say, doing running, but they're not better at field events. So it's the right body type. Do they like that particular sport that they're being channeled into? Suppose we go to you and you say, no, we want you to run, but you don't like running, but you like basketball, wheelchair basketball. It depends. All right, can the athlete manage the demand for the sport? Swimming, take for example, is an extremely demanding sport. It requires training sometimes twice a day, or early in the morning, late at night. If the athlete just cannot go up to that, then that is not the sport for them. Are they a good team player, or would they prefer to do an individual sport? So these things can factor in to performance. In terms of muscular strength, power, flexibility and speed, looking up an article, it said competitive athletes spend much of their time in the pursuit of these performance enhancements. Often, however, coaches and conditioning specialists treat each component as a separate area of training and do not give equal importance to all areas. But of course, we find that power production and flexibility are the two areas that receive the least attention, but they're actually the two most important areas to enhance performance and then obviously have a better athlete. And I will mention here that in discussion with Dr. Martin, she is working with a group of hockey players, right? And they are doing a strength and conditioning program using water, and trust me, aquatic therapy is fabulous. And it's boys? They're doing boys and girls, and they're doing really, really well in terms of their conditioning and their power, and they are fit and stepping up. So really, power production, flexibility, strength and conditioning, very important. And certainly all athletes prior to getting involved in a program or in any form of sport should be assessed, evaluated by whether it's a sports medicine specialist, orthopedic surgeon, athletic trainer, strength and conditioning coach, and in Jamaica we have physiotherapists, not all of them. I mean, we're all trained exercise. We can train persons in exercise, that is our field. And so if you don't have an official strength and conditioning coach, the physiotherapist does a great job. Alright, in terms of nutrition, it is the position of the American Dietetic Association, Dietitians of Canada, and the American College of Sports Medicine that physical activity, athletic performance, and recovery from exercise are enhanced by optimal nutrition. So nutrition is really important. Now, what are the considerations? Special dietary needs of the athletes, certainly for those who are vegetarians or those who don't eat, say, beef and chicken or whatever. Special nutrient needs during training and competition, definitely. Support of a sports dietitian, that is needed in this country. Body composition and weight management, energy needs of the type of sport, and the use of supplements. And those of you who were there this morning heard that Janko said they don't support the use of supplements. Oh no. Anyway, continuing on the nutrition, energy and macronutrient needs, especially carbohydrate and protein, must be met during times of high physical activity to maintain body weight, replenish glycogen stores, and provide adequate nutrition to build and repair tissue. Fat intake, of course, should be sufficient to provide the essential fatty acids and fat-soluble vitamins, as well as contribute energy for weight maintenance. Although exercise performance can be affected by body weight and composition, these physical measures should not be a criterion for sports performance, and daily weigh-ins, of course, are discouraged. So you don't athletes focusing on weight. Now, adequate food and fluid should be consumed before, during, and after exercise to help maintain blood glucose concentration during exercise, maximize exercise performance, and improve recovery time. And of course, athletes should be very well hydrated before exercise, drinking enough fluid during and after exercise. And sports beverages, again, it's not everyone that is out there on the market that you should drink. Vitamin and mineral supplements, this article said they're not needed if adequate nutrition is there, but we know in our environment where finances are limited, it is a challenge to really eat the right, properly balanced diet. And I will move on since I got a 2-minute signal. A qualified sports dietitian, and in particular in the United States, a board certified specialist in sports dietetics, should provide individualized nutrition, direction, and advice subsequent to a comprehensive nutrition assessment. In other words, if you can have a sports dietitian, that's great. In terms of equipment, if you have the right, if you are involved in a sports, so say for example field events, you want to start out with a stool that is low cost, and then when the finances pick up, you get to something that's of course at the level of high performance. And so hence why we are in field events, because that is low cost. High cost is your running legs, your blades, that can be running in the region of 10,000 US and up. And guess what? The wheelchairs, the racing wheelchairs, run in the region of 3,500 US. And I don't even talk about the basketball wheelchairs and the rugby chairs. We're not into rugby, but I'm just saying, these chairs cost a lot of money. In terms of training opportunities and accessibility, athletes should have a facility in which to train that is accessible. As you've heard, most of it occurs at Sir John Bowling, which is accessible, but now we have athletes basically all around the island, and we want to ensure that all facilities are accessible. And that would be nice. And so if you have the facility to go to train, then that does enhance your performance. If you have the gym equipment for strength training, and the pool for the aquatic therapy training, coaches, and so you must have a medical team, which must include coaches, massage therapists, physios, doctors, athletic trainers if they're around. If you have the strength and conditioning coach, a sports psychologist. I heard somebody earlier this morning said he's a sports psychologist, and we need much more of them here. Access to appropriate equipment with which to train, and as I mentioned, I mentioned all of them, the wheelchair, the different types of wheelchairs, the simple equipment for field events like the discus, shot put, and javelin. If you don't have it, how are you going to train? All right, transport to even reach training in some cases, and you know, is the training taking place somewhere near to their home, or is it that they have to come to town for it? And can they train daily, 5 days a week? The knowledge of the coach is important. Coaches are certified, and you have different level coaching courses. It's actually easier to recruit coaches in a sport and teach them to work with athletes with a disability than to recruit people who know about disability and teach them the sport. I'm not going to spend much time on that. Coaches do learn to overcome their fear of persons with disabilities. But coaches, of course, must be passionate about their sport so they can transfer that to their athlete. And it's easier to actually take an athlete to the Paralympic Games than it is to an Olympic Games, but it's limited now at the Paralympic level because of what we call the quota system that Dr. Dixon mentioned earlier. From the financial side of things, do the athletes have a job that can pay them well enough to even cover their basic needs and be able to go to training and eating the right kinds of food? Alright, is it full-time or part-time? Do they have the flexibility to train regularly? I mean 5 days a week at least. And can we, the Jamaica Paralympic Association, assist the athlete with getting to training or in any way with the financial support? And I know in the States, I think most athletes are actually paid a stipend for training, but we don't have that. Alright, psychological support goes back to the coach. I mentioned the sports psychologist, even the athlete's family, your support network, the medical team, and the athlete's own self-motivation, their self-esteem, and their self-confidence. I just wanted to mention the role of the sports psychologist. One is to enhance performance, and I won't go into the details of it. Cope with the pressures of competition and recover from injuries, and even to maintain their exercise program, because they may feel a little lazy. Oh, I don't feel like going out there today. But no, that is the role of the sports psychologist, to help to keep them motivated. All right, in terms of the IPC, they want to empower para athletes and support the development of para sports, and it goes into, you know, providing opportunities for athletes, and I'm not going to spend time on that. In terms of the JPA, what we do is provide as much as possible support for the athletes through our sponsors, and we assist them to attend training. This is all financial. We organize accommodation where possible near training, and we have done that in the past. We organize training opportunities with coaches, especially for those in rural areas. We organize local competitions. We've done 3-on-3 basketball, and we, as Dr. Dixon said, we're part of the UTEC Classic. And of course, we have to pay for the athletes to go to regional and international competitions. And Dr. Dixon is the classifier, so we provide opportunities for classification. And we have a local ophthalmologist, Dr. Maynard McIntosh, who classifies the blind and visually impaired athletes. And then, of course, they have to go abroad to get the official classification. And then, of course, we liaise with the International Paralympic Committee and other international federations. And we seek coaching support. And just to say that, remember, we're not only in athletics, we're in rowing, we're in taekwondo, we're table tennis. So coaching support from all of these sports federations. And we seek members of the medical team to support athletes. We provide educational opportunities for athletes to advance. And I mentioned anti-doping, and this should be the last 2 slides. JADCOG basically did a presentation, so we just make sure that our athletes know and understand that they have to go to the seminars that take place, that they consult Dr. Dixon, no, I should say, but Dr. Dixon is the main doctor that they come to about what supplements they can take, because the truth is every athlete takes something until it becomes bad. But there are supplements that are safe. Can I say that, Dr. Dixon? I don't know. Maybe Jack might. But every athlete takes something. The nutritional support that we're getting is just not enough. So, yes, and I did say that. Oh, and we liaise with JADCO to ensure that there is anti-doping testing at the UTEC Classic, so that will happen. Just a little note on injury prevention, flexibility. Athletes tend to be very tight in their hamstrings, so they need to stretch a lot, and we the physios can teach them the stretching technique. The shoulder muscles they have to stretch, and they need to warm up and cool down, and massage, very important. We the physios can do that, or if you have the massage therapist. And we did say adequate hydration and nutrition, and of course the correct techniques when they're doing their strength training and when they're doing the throwing events, so that they don't injure themselves. And I do believe that's it. Thank you very much.
So much rich information. Thank you, Susan, Henry. And I don't even need to summarize what each panelist presented. I'm sure it is so well absorbed. But in the interest of time, I will take just one question from this end, one from the middle, and one from the far end. Okay, Mary, you want to be the first? Please do, yeah. Mike? Can I get a mic to Mary, please? All right, let me see if I can use mine here. Let me work the floor.
Good afternoon, everyone. Mary Michelle Coombs, disability advocate. Although I'm visually impaired, because we are from the Combined Disability Association, I try to make myself as familiar as possible with other disability groups and their needs. And I tried to listen keenly to the presenters, and trust me, them good. Yes. But my concern really, you see me, when I see the black, green and gold anyway, it do something to me. Trust me. And when we have our athletes go away and perform, and we see them come back and we watch TV and we see them, we feel good, don't we? Yes. Right. But the administrative part of it, the preparation as part, documentation part of it, the anti-doping part of it, it's all well and good. But over the few days we are here, we heard about the challenges that we face as disabled persons. And a great percentage of our people are unemployed. We heard the minister mention about the little thing that is given to all groups. How much time we have our athletes who might be even hungry and have proper something to eat? I might be that some time and eat something enough to eat because we don't have at the time. You know, what is being done for these people who are representing us, internationally especially, to see to it that they are taken in because they are representing our country, and giving the type of need, feeling the type of need that they have. Trust me, people, our athletes don't feel no way, but we know sometimes we don't have money. Right? And we should have, in this subvention or whatever is given to the different groups, the priority should be making a little contribution, a little typing to the people who are representing us.
Thank you.
That's what we do. Trust me, I hope we really look into it, and trust me, we don't have the recognition of these persons that we should have. When we see our athletes come back, the able-bodied athlete, the entourage at the airport is massive. And when our people come back with more medals than what those people have, the 1 and 2 people without the field, you have to take microscope to see them. We want to change that because we are making a valuable contribution to the development of this country, just like everybody else. And trust me, thank you again, presenters, for those wonderful things, but we want a little more hands-on for the individuals that are bringing us this real, rich contribution to this country.
Thank you. Thanks for that. I don't know if you have a panelist and I want to make a commentary on that and also to address the question as to whether or not our disability, active disabilities are included in the new insurance program for athletes.
Yes, and our para-athletes are included in it as well. Well said, Mary. Just to say in terms of the stipend, we would love to, but the financial resources and the little, we get a stipend from the Sports Development Foundation. It is for us a stipend as well, and it's not significant to really run the association and do what we would like to, but it's not to say that we have not, we're not looking into all avenues. We're looking into the avenues of supporting with nutrition, but it takes time.
Yeah, request a contribution to media? Thanks. Go ahead, please.
Good afternoon, peace be to you. I'm Ban St. Elizabeth. Listen very keenly and observe and want to comment briefly and a question also. You mentioned about rehab and costs and assess. Well, I fall in those areas also where heavily financially embarrassed, and because of that I'm muzzled on every avenue and would like to reach a maximum in everything, but because of the financial restraint I'm crippled. I hear the talk and everything, but talk is good, but we need action there, sacrifice, true? And secondly, I don't fall in the sports arena, so am I left out? I love to propagate the world with the gospel of Jesus Christ. Am I drop out of this? What's there for me also? God bless.
Thank you, thank you. Thanks for that. Any additional intervention from the floor? Okay, thanks.
Dennis, just one quick.
Sure.
I think what the gentleman back there was referring to could be like recreational sports, because the reality is, yes, not everyone is going to get into competitive sports, and where I would love to see the disabled community get to a point is recreational sports, because when myself and Christine and the ladies went to the States, I mean, you have recreational therapists and they have recreational sports programs, so you don't have to do it at a competitive level. You can just do it for exercise to prevent obesity and everything else and all the non-communicable diseases. Thank you.
Sure.
Good afternoon. Just a suggestion, this might be something that you have already done, but in terms of accessing help from international organizations, those are also available. So places like UNESCO, UNAID, those places will also give assistance.
Thanks a lot. And perhaps if I might ask Dr. Martin, Dr. Dixon, what is happening in your new faculty with respect to sports and medicine regarding community of persons with disabilities?
Actually, what drew my attention was Suzanne's comment about the coaches and coaches not feeling comfortable working with persons with disability, and I smiled to myself because we're currently in the process of having our BSc sports coaching curriculum approved for September start, and in the curriculum we specifically have courses on adaptive sports science. So I'm hoping that, as our batch of graduates in sports coaching comes out of UWI, we'll be producing coaches who are better equipped and are more comfortable with going out to work with persons with disabilities, because we're anticipating that these people will go into the school environment, which will then develop adaptive sports for recreation purposes within the school. We have structured phys ed with phys ed instructors that come out of our programs here in Jamaica. But I'm not sure to what extent those programs target adaptive sports. I mean,
GC Foster is just developing theirs as well.
Right. So we've put it into our curriculum, and we're hoping to see that develop some more. I think over the upcoming years, you'll also see us at the Academy of Sport becoming a little bit more involved with some of the training side, because first we're looking at research and intervention into training across the spectrum of our athletes, not just the able-bodied.
Fantastic. And I'll give the last word to Dr. Dixon in terms of this presentation series. Thanks.
And from a medical point of view, every single patient that presents to us at the center is asked about their exercise activity, if they currently exercise, what were they active, did they have a sport or whatever, and whether or not they plan to compete. It is encouraged to find an activity that you like, or I said, do it for the love and not for the like.
Alright, well, it's a chronic system.
Yeah, find an exercise that you love, and just make it a habit.
Great. Okay, thanks, Dr. Dixon. Thanks, panel. And could you give a final round of applause? But before you go, let me ask a number of our membership here to make a presentation to our respective panelists. Okay, and could I ask Mary to present? And then Wilbert. Wilbert, emphasis.
Done it again.
Okay.
Come with
Ready? All right, yeah. And thirdly, I also ask. You're gonna present. Yeah. Okay. Taylor. Yeah.
Susan first.
Susan.
Yeah, yes sir, I'm coming.
It is my congratulations. Well done. It is my pleasure to give you this certificate.
Okay, thank you.
Picture check.
Thanks, Wilbert. And I'll ask Mary to present to Dr. Dixon.
Dr. Dixon, on behalf of all of us, I just want to present you with a token as a sign of our appreciation for the informative presentation that you have made. And we just want to say thanks.
Finally, I ask Taylor to present to Dr. Martin. Author, rather. Okay?
Yeah.
No, sir. No, sir.
Oh. This week?
No, sir.
Right about hard road. Dr. Martin, this token given to you, it's one of great encouragement for you to continue to work and to work harder at what you're doing. And we really hope that you're encouraged. We certainly can express our appreciation in having you here today. So may God continue to bless you. We're looking for the clicker here, and the clicker down here. Keep laughing.
It's all right, the cameras don't kick in.
So let me just conclude by thanking you all.